Alright guys, now that y'all had a chance to take a break, we're going to go over some ways that we open our airway. So the following are techniques that we use to open and maintain a patent airway. If we need to do it manually, we'll use either a head tilt chin lift or jaw thrust. Mechanical airways such as an oropharyngeal or OPA, or a nasopharyngeal or NPA if we need to insert some type of mechanical adjunct, or we'll just simply suction out the patient if there's fluid. The head tilt chin lift, we use this when there's no spinal injury suspected. To do this, you place one hand on your patient's forehead and apply firm backward pressure with the palm of the hand to tilt the head back. Place the tips of the fingers of the other hand underneath the bony part of the lower jaw. With the head tilted backwards, lift the jaw upward to bring the patient's chin forward. Do not compress the soft tissues underneath the chin. That might obstruct the airway. You then continue to press the other hand on the patient's forehead to keep the head tilted backwards. Lift the chin and jaw so that the teeth are brought nearly together. If necessary, you can use your thumb to depress or retract the lower lid. This keeps the patient's mouth slightly open. If the patient has any loose dentures, hold them in position, making obstruction by the lips less likely. A seal is easier to form when the dentures are in place. If the dentures have become loose and cannot be managed, remove them away. So you'll place that hand on the forehead, one underneath the jaw, tilt the head back, and lift the jaw up. With an infant, the head should be tilted back gently into a sniffing or neutral position. To achieve the sniffing position, the opening of the ear is lined up horizontally with the sternal notch. You may also want to consider taking some padding, such as a blanket, towel, something like that, and place it beneath the shoulders to bring the shoulders up and keep the head, neck, and chest all in line. The jaw thrust maneuver, we use this when some type of spinal injury has been suspected. To perform the jaw thrust maneuver, the first thing you want to do is kneel at the top of the patient's head. Place your elbows on the surface on which the patient is lying. That way you have a bit of a fulcrum. Excuse me. Then place your hands at the side of the patient's head. Grasp the angles of the patient's lower jaw on both sides. Move the jaw forward with both hands. This moves the tongue forward away from the airway. If no spinal injury is suspected, the head could be tilted backwards. Then retract the lower lid with your thumb if the lips closed. So see, you lift the mandible forward and keep everything in a neutral inline position. In infants and children, same basic procedure as that for an adult. You're not going to do anything much different. Just going to place 2 or 3 fingers of each hand at the angles of the jaw to lift it up and forward while the other fingers guide the movement. If you need to, you can insert an airway adjunct if the jaw thrust does not completely open the airway. If the patient has an altered mental status and may be at risk of aspirating blood, secretions, or vomit, place the patient in a modified lateral or recovery position. This is also known as the coma or recovery position. This positioning is used only in patients who do not have a suspected spinal injury and in patients who are not in need of positive pressure ventilation. To ventilate a patient effectively when no advanced airway device is in place, the patient must be in a supine position. So you're going to place them on their side, so in case they go to vomit, there's less of a chance of them aspirating. What I would generally recommend if you are having to do this is take your truck into consideration. So that way, if when you go to load the patient in with your patient laying on their left side, you would want if you're in a van type ambulance, you would want it to where her back is towards your supply compartment, your supply shelves, and not the other way where now all she's doing is looking at a wall. Now, it may also be necessary to place the patient on their side when suctioning, so that way you can perform a finger sweep to remove the material if the rescuer visualizes it. Now, you may want to make sure that it is operating properly so that way it can generate enough negative pressure to remove fluids from the airway effectively. Only apply suction when withdrawing the catheter, and if possible, do not suction for more than 15 seconds, but make sure the airway is clear before ventilating. Suctioning can cause hypoxia, so you want to make sure that you're monitoring the heart rate while suctioning the patient out as well. When suctioning a patient, you want to make sure that you're taking standard precautions, whether you're going to want to make sure you have on protective eyewear, mask and gloves should be worn. If you suspect a patient may have tuberculosis, you also want to put on a N95 or HEPA respirator to protect yourself. Your suction equipment can come in a variety of different ways. It can be fixed or installed within your unit. This is actually a required piece of equipment on board the ambulance. They should be powerful enough to provide an airflow of 740 liters per minute at the end of the delivery tube and create a vacuum of more than negative 300 millimeters of mercury on the gauge when the tubing is clamped or kinked. A portable unit must also be able to provide a vacuum adequate to provide produce a vacuum adequate to suction substances from the pharynx. A pressure of negative 80 to 120 millimeters of mercury is generally necessary to provide adequate suction. The device should also be capable of generating negative 300 millimeters of mercury of pressure when the suction hose is clamped. Portable suction units can be electric, oxygen, air, or hand-powered. Suction catheters must also be disposable and capable of being connected to the suction unit's tubing. Two different types of suction catheters are available: rigid catheters and soft catheters. Rigid catheters, we'll generally use these in our unresponsive patients. We want to insert it only as far as you can see into the mouth. We don't want to go too far back, and we want to avoid touching the back of the oropharynx. Not only one, to reduce the chances of activating the gag reflex, but also to reduce any potentiality of causing any damage. Soft or French catheters, these should not be inserted beyond the base of the tongue, and so you want to make sure that you avoid inserting it too far, because once again you can cause too much damage. But we'll use these to suction out the nose or nasopharynx. When preparing to suction, the first thing you obviously want to do is assemble and turn on your unit. Position yourself at the head so that way you can observe the airway throughout the entire process. Make sure you have the appropriate type of catheter. If you're suctioning out the mouth or pharynx, you want to make sure that you're using a rigid catheter, whereas if you're doing the nasal passages, you want to use a soft French catheter and use low to medium suction. Standard suction pressure for an adult is 100 to 120, a child is 80 to 100, and an infant is 60 to 80. It is commonly recommended to use the lowest vacuum pressure possible to avoid hypoxia. A bulb syringe may also be used if a soft catheter is not available. You then want to measure the catheter and insert it into the oral cavity without suction, if possible. Insert it no further down than the base of the tongue. You then apply suction only on the way out of the airway. Begin suction after the tip has been positioned, moving the catheter tip from side to side to clear material from the mouth as the catheter is being removed. If possible, suction for no more than 15 seconds at a time in the adult. In infants and children, suction in shorter periods, approximately 5 seconds. However, it is necessary to provide suction until the substance is clear from the airway to prevent aspiration from spontaneous or artificial ventilation. If necessary, rinse the catheter with water to prevent obstruction of the tubing from dried or thick material. Do this by keeping a bottle of water available and applying suction to the water necessary to clear the tubing. Some considerations you want to take when suctioning. If the patient has secretions or vomit that cannot be removed quickly, the patient should be log rolled onto their side and the oropharynx cleared by finger sweeping the foreign material from the mouth. If the patient is in need of artificial ventilation and they're producing frothy secretions as rapidly as suctioning can remove them, apply suction for 15 seconds, apply positive pressure ventilation with supplemental oxygen for 2 minutes, and then apply suction again for another 15 seconds. During suctioning, the residual volume of air in the lungs between respirations is removed. Residual volume is defined as the air remaining in the lungs after a maximal exhalation. This causes a quick decrease in blood oxygen levels. Therefore, make sure you're monitoring your patient's pulse and their heart rate and pulse ox reading while suctioning. In the adult patient, a rapid heart rate, slow heart rate, or an irregular heart rate may be seen during suctioning. These can occur from stimulation of the airway by the suction catheter, or it may be an indication the oxygen level in the blood is getting dangerously low. Before suctioning mucus and small amounts of secretions in a patient who is being artificially ventilated, ventilate him at a rate of 10 to 12 breaths per minute for 5 minutes to wash out the residual nitrogen and increase the functional oxygen reserve. Airway adjuncts, you want to make sure that your adjunct is clean and clear of obstructions. We generally use these in work with a manual airway. You want to make sure that you're using the proper size of the adjunct to avoid any complications and ineffectiveness. Now keep in mind though that these adjuncts do not protect the airway from the patient aspirating on any secretions or blood. Also, the mental status of the patient and any potential injuries will determine whether an adjunct can be used. The patient's mental status must be continually and carefully monitored. If the patient becomes more responsive or gags, remove the airway adjunct. A head tilt, chin lift, or jaw thrust maneuver must also still be maintained, even when an airway adjunct is in place and properly positioned. Now, oropharyngeal airways, these can be used in patients who are unresponsive and do not have a gag reflex. These must be sized properly because if you put them in too big, it's going to cause the airway to become obstructed, and if you put it in too small, it's not going to do anything. These are your OPAs. You want to make sure that you are using the proper size, and we will go over how to properly size these in class. In an oropharyngeal that is properly placed, the OPA will come just behind the tongue and will help keep the tongue from falling back to occlude the patient's airway. In children, we use an alternative method of inserting the oropharyngeal airway. This involves the use of a tongue depressor. The tongue depressor is inserted into the mouth until its tip is at the base of the tongue. The tongue is then pressed down towards the mandible and forward with the tongue depressor. The airway is inserted in its normal anatomical position until the flange is seated on the teeth. This is the preferred method of airway insertion in infants and children. The nasopharyngeal airway, or NPA, is a curved hollow tube of soft plastic or rubber with a flange or flare at the top end and a bevel at the distal end. Be careful to select an airway of proper length. Avoid use of the nasal airway in patients with a suspected fracture to the base of the skull or severe facial trauma. Nasopharyngeal airways also come in a variety of pediatric sizes. So in very young patients, the nasopharyngeal are so small that it is easily obstructed by secretions and other upper airway substances. Children may have large adenoids, which make insertion of the nasopharyngeal airway difficult. This makes the use of a nasopharyngeal airway in the very young ineffective. So you have your bevel on one end, you have your flange on the other. Now when you go to insert an NPA, you want to do it where bevel is in or in towards the septum or middle of your nose, and then just let it guide in. Now it's imperative to assess the relationship between the volume or amount of air taken in with each breath and the rate at which the patient is breathing when determining whether the patient's breathing is adequate or not. When looking at the relationship, you want to make accurate decisions about the adequacy of a patient's breathing. So we want to make sure that we understand the relationship between respiratory rate, tidal volume, and the amount of air reaching the alveoli for gas exchange. Now, minute ventilation is determined by multiplying the respiratory rate by the tidal volume. Only part of the tidal volume actually reaches the alveoli for gas exchange. The dead air space above the alveoli is approximately 150 milliliters. Assist patients with inadequate alveolar ventilation using positive pressure ventilation to correct and prevent hypoxia. Also, any respiratory rate greater than 40 per minute results in a decrease in tidal volume, reducing the minute volume and alveolar ventilation. Minute volume, as I said, is tidal volume times respiratory rate. Both adequate and inadequate breathing depend on two specific variables: the rate at which the patient is breathing and the depth of each breath. Because minute volume deals with both depth and rate, it typically correlates with how adequately the patient is breathing. A decrease in either the tidal volume or the respiratory rate may lead to a decrease in minute volume, so severe that the patient is no longer moving an adequate amount of air per minute in and out of the lungs. It is not important for the EMT to determine the actual minute volume value. However, it is imperative to assess both respiratory rate and volume when determining whether the breathing is adequate, because a change in either of these could lead to inadequate breathing. Alright, so I'm going to show you an example real quick of what the minute volume is. Let me get my pen. So, minute volume equals tidal volume times respiratory rate. Alright, so, and y'all sorry for my wonderful handwriting. So let's say the patient has a tidal volume of 500. Each breath they breathe in is 500 milliliters. And your patient is breathing 12 breaths per minute. That would mean that your patient has a minute volume of 6,000 milliliters. That is how much air the patient is breathing in every minute. Only the air that reaches the alveoli can be used for gas exchange, because the trachea and bronchi do not participate in gas exchange. Because of the effect of dead air space on ventilation, small decreases in tidal volume can dramatically reduce the amount of air reaching the alveoli for gas exchange. So alveolar ventilation is tidal volume minus dead air space. Okay? So using what we were talking about earlier in the last slide, if you have a 500 milliliter tidal volume and you have a dead air space of 150, that means that you have to get 350 milliliters of air in order to be able to adequately survive. So if you start breathing faster, it does not mean that you're increasing your volume. You're actually decreasing your volume. So now you might only be breathing in 300. So now you're only getting 150 milliliters of air per minute into the alveoli, which is not enough to live. When assessing, you want to go look, listen, feel, and auscultate the chest. When looking, you want to inspect the chest. We are actually looking at it. We want to expose the chest. We're looking to see if the chest wall is rising and falling bilaterally or together. We want to look for any retractions or pulling inward of the intercostal muscles of the chest, as well as excessive use of the neck muscles during inspiration. In an unresponsive patient, you should place your ear near the patient's mouth or nose while looking at the chest, and you can simultaneously look, listen, and feel for air movement. You also want to look at what the patient's general appearance is. Does he appear to be anxious or uncomfortable or in distress? Are they laying down or sitting erect? Does it appear that the patient is straining to breathe? You want to look for use or straining of the large muscles in the neck. Decide whether or not the breathing pattern is regular or irregular, and you also want to look at the nostrils to see if they're flaring open during inhalation. You then want to listen. How are they speaking to you? Can they only say a few words at a time before they have to catch their breath? If the patient is unresponsive, listen, like I said, and listen to their nose and mouth and listen for that air movement. Auscultate breath sounds. See what you can hear down in the lower lungs. Feel, as we've said multiple times, if you don't want to put your face down near the patient, put the back of your arm over their mouth or nose and feel for it that way. Also, with listening, listen for any audible sounds coming from their mouth. And then auscultate, as I've said before, auscultating breath sounds. You want to listen and on the front side at 4 different spots, 2 inches below the clavicle at the midclavicular line, and then also the mid-axillary line a few ribs down. I would also recommend listening to them on the back side as well, because you can also sometimes hear some different sounds. Any abnormal sounds or diminished or absent sounds indicates inadequate breathing as well. So on the front, you should always auscultate on 4 points, and then you should also listen to these points on the back side as well, and then listen to the mid-axillary on either side as well. You want to assess the patient's respiratory rate, the rhythm, quality, and the depth of the breath as well. Now, the respiratory rate, you want to be sure that you're taking into consideration the age range of the patient, because the respiratory rate for an adult is, at 12 to 20 per minute, 15 to 30 for a child, 20 to 30 for an infant, 25 to 40 for an infant of, from a month to 5 months. And for a newborn, it's 30 to 60. And then elderly, it could be more than 20 per minute. So take into consideration the age of the patient and any comorbid medical conditions that they may have. If the respiratory rates are too low, even though the tidal volume may be adequate, the patient may not be moving enough air into the lungs and alveoli to meet the oxygen demands of the cells of the body. You want to look at the rhythm. Does the pattern appear to be regular? Each breath is of about the same volume and comes at a regular interval. However, it is normal for a patient to sigh, which alters the pattern and makes it slightly irregular. You want to assess the quality of the breath. Are the breath sounds equal and full bilaterally, indicating good expansion of each lung? The chest should rise and fall adequately and equally with each breath. No excessive accessory muscle use is seen with inhalation and exhalation. It is normal for infants and children to use the abdominal muscles more than adults do in breathing. Therefore, expect greater movement of the abdomen with these patients. And then you want to look at depth. This is measuring the tidal volume. The chest should fully rise with each inhalation. The volume of air felt and heard by placing your ear next to the patient's mouth and nose should be full and adequate with each breath as well. Table 10-3 goes over some signs of adequate breathing. Look at chest rise, normal respiratory rate, clear breath sounds. Inadequate breathing could potentially lead to hypoxia. Now there are multiple causes of a patient potentially going into respiratory arrest, such as a stroke or a heart attack, drug overdose, suffocation, or electrocution. So we want to determine what is going on, because if the patient is not breathing adequately, the brain will begin to die within 4 to 6 minutes of that inadequate breathing. If you do have a patient that's in respiratory failure or arrest, they do require immediate positive pressure ventilation. A type of respiratory pattern that is commonly inadequate and may be seen in witness cardiac arrest or in some other conditions is called agonal breathing or agonal respirations. Agonal respirations are gasping type breaths. If seen in the cardiac arrest patient, they usually appear soon after the person goes into cardiac arrest. They are totally ineffective respirations. A patient with agonal respirations must be provided positive pressure ventilation. With inadequate breathing, there are signs of them. You want to look at the rate. Are they tachypnic or bradypnic? Are they breathing too fast or too slow? Are they breathing irregular? Do they have abnormal breath sounds or breath sounds that are decreased or absent? Are they breathing shallow? Are they breathing labored? Any sign of these is a reason to artificially ventilate your patient. In Table 10-5, it goes into more details with the abnormal work of breathing. Do you see signs of nasal flaring or retractions where the body's doing everything it can to get air into the body? Are there any abnormal breath sounds, stridor or wheezing or crackles? Is there a reduced minute ventilation? Do they have a decreased tidal volume or decreased chest rise? Do you see signs of paradoxical chest wall, where the chest wall segment is moving in during inspiration and out during expiration? This would be a sign of a flail chest segment. Is there an irregular respiratory pattern, or a rapid respiratory rate without clinical improvement in the patient's condition? Now, not all signs of inadequate breathing are present at the same time. Any of these signs, a breathing rate that is too slow, a shallow depth, a poor quality, or inadequate tidal volume by itself is a reason to artificially ventilate a patient without delay. To have adequate breathing, the rate of respiration and the tidal volume must both be within adequate limits. If either is inadequate, the patient must be provided with positive pressure ventilation, which is artificial ventilation. This requires you to pay close attention to the chest wall during activity during the assessment. If the chest wall is moving minimally and very little air movement is heard or felt, you must immediately intervene and provide positive pressure ventilation to the patient. So if you have adequate respiratory rate, adequate volume, they're breathing good. Just apply oxygen. If they're breathing if it has an inadequate respiratory rate but adequate tidal volume, immediately begin positive pressure ventilation. Same thing if they have an adequate respiratory rate but inadequate tidal volume, provide PPV. Alright guys, we're going to take another break here. Stretch your legs, go to the restroom. If you have any questions, just let me know, and I will be back in just a bit.